Well, thank you very much, Ian, for that dubious introduction. It's interesting. I think he must have seen my slides because there is something of a footballing theme that might emerge during this morning, but we'll leave it at that for now. For those of you who haven't been to this conference before, and I gather there's quite a significant number this year, welcome. I think, I know you'll enjoy it, and much of many of the benefits are not just at these sort of structured parts, but the intermingling that takes place at the various social events and so forth. So it's really, really good, and it's really good to know that there'll be some people in the audience that haven't seen all my slides before. So when I got this title, which is a bit different, I did kind of adjust it a little bit. But getting back to the basics, that sort of struck a sort of sporting theme to me. And so I thought, who should I go and see to get some advice about how to deliver this talk? And of course, Rafa came at the end of last season and didn't achieve anything, but has achieved something this season. And I think he's certainly a man. He's in fact moved or has a flat. He still lives in the Northwest, but he has a flat next door to a patient of mine. So I get some insights into what's going on. So anyway, I knocked on his door and I said, Rafa, I've got this talk to give. You've obviously been an inspirational figure in Newcastle. I need some advice. And I'm talking not at a scientific conference full of expert doctors and scientists. A bit like you, I've got some, footballers, and they don't perhaps fully understand all the issues that you have to get over. So he said, well, the first thing is, first step, you've got to get to basics and keep it simple. So you're not going to hear anything flash or difficult from me. It's just going to be skimming over, I think, the important issues for you. He said, yeah, so you mustn't confuse either the players or, for you, the audience in terms of making life too complicated. So we're going to definitely keep it straightforward. But if anybody stands up and disagrees, just get rid of them. That's a very important part of activity. So what is pH? And I think it is important just to think a little bit at this point and to have some understanding of how our bodies and how our heart and lungs interact to make it a little more obvious to you as to where the problem is and why we do what we do to try and fix it. So the right ventricle, which is the pumping chamber sensibly on the right side of the heart, pumps blood that's low in oxygen through the lungs via the pulmonary artery. And the blood leaves the lungs, oxygenated, comes back to the left heart, but obviously the right ventricle is the important pumping chamber, again, to deliver blood to the lungs and take it out of the lungs and back to the ventricle. And that's a very important part of what goes on, because for the rest of the organs in the body to function, they need oxygen and other nutrients. And so of the two circulations, the circulation of blood through the lungs to pick up oxygen, and then the distribution of that oxygenated blood to the rest of the body, the brain, the kidneys, the liver, so on and so forth. They're both equally important. And when you go into the lay public, or you hear on the news or something, hypertension, everybody thinks about a disease that's associated with putting a cuff on the arm and measuring the blood pressure. But people fail to recognize that in terms of everybody in this audience, we're more focused on the pressure of blood within the circulation through the lungs. And of course, there's the first problem for us in many ways, because it's very easy to measure the blood pressure of blood going around the body by having a sphygmomanometer, as it's called, around, or other devices now. around the arm. You can measure the pressure accurately without doing anything. But in measuring the pressure within the chest, yes, and we'll talk about these in a little while, you can use indirect measures of the pressures, but you can't directly measure it without having the right heart catheter. We'll come on to that in due course. So what is pH? Well, it's very simply the pressure of blood in the pulmonary artery rises. And it leads to, if you like, a back pressure towards the pumping chamber, the right ventricle of the heart. And it's a bit like the system we have here. If you can imagine that valve being turned down so that the resistance of whatever liquid's going through that pipe increases, if flow continues, the pressure will build up, and ultimately the pulmonary artery and the right ventricle on the other side of the constriction will start to dilate, and ultimately the pump that's driving that will end up failing. And that's really, certainly for pulmonary arterial hypertension, and we'll come on to that also in terms of the different forms of pulmonary hypertension. That's a simplistic way of considering what's going on. Now I'm going to show a video to tell you a little bit more. I hope nobody's too squeamish. That thing that's pumping in front of you is the heart, quite clearly. What we know is that the blue vessels are the deoxygenated vessels, or blood carrying no oxygen. The blood flows normally through your pulmonary arteries in your chest like that, and you can see that there's a nice big wide pipe. But when you've got pulmonary hypertension, or certainly pulmonary arterial hypertension, the endothelial cells, those smooth cells within the lumen, start to secrete various substances they call smooth muscle and other scar-forming cells, fibroblasts, and you can see that that pipe constricts up. It furs up a bit like a pipe in a domestic hot water system. And that's the problem. And that's the problem that we need to get to, because that narrowing of the blood vessels starts to put a strain on the heart here, just about to emerge. If we have a look at that pumping heart from within, the pumping chamber starts to get bigger and bigger. The muscle starts to get thicker, so it adapts initially. But in time, there's a gradual and progressive worsening of the function of that heart. And that very simply is, if you like, what is going on physiologically or anatomically in the chests of patients with pulmonary hypertension. And although it's primarily an illness that affects the blood vessels in the lungs, the downstream effects on the right ventricle, as we saw there, leading to potentially failure of the heart. When I say failure of the heart, I don't mean it suddenly stops. All I mean is that its pumping ability becomes less efficient. It's that inefficiency that actually leads to the symptoms that bothers those of you with this condition. It's the inefficiency of the heart that leads to fatigue, which is a very common symptom, as you all know, the breathlessness, ultimately fluid retention and swelling. And as the situation progresses, sometimes significant chest pain on minimal exercise, and sometimes blackouts, or the feeling that you might black out when you're about to exercise. So it's the failing heart that leads to the worsening health-related quality of life and exercise limitation. But that failing heart is all related to the increased resistance of blood flow through the lungs. And that's why we target the blood flow through the lungs as one of the principal aims to try and get you guys better. So I'm interested to know, pulmonary hypertension is a term, and it encapsulates a huge number of different conditions. So how many in the audience have pulmonary arterial hypertension, either idiopathic or heritable or associated with congenital heart disease or systemic sclerosis or other connective tissue diseases? Those are probably the major. I would have imagined the majority would have this. And yeah, very good. All right. So I want to hear a little shout from you guys. You all awake and listening? Okay. Yeah. Brilliant. What about maybe not so many of you have got principally left heart disease? I would imagine not so many here. No. Okay. That probably is a very good thing. What about patients with primarily lung disease that's driving it? Any? No, and again, I would have guessed that was also the case. What about the CTEPHs? I'm sure there are some CTEPHs in the audience. Yeah, jolly good. Okay, so you're in the right conference, because most of what you're going to hear about will be related very much to ways of treating and ways of helping patients predominantly with what we call group 1 and group 4 disease here. And I'm sure there may be someone saying, what about me? What about me? Well, we have got, anybody, what about me's with something else, something rare and interesting or not? No, good. So the main point here is you will, I think, be hearing and talking to people predominantly with good discussion points around that are important for you. So Rafa, yeah, he was just caught off guard here, because when I asked him, I'm going to have to explain to the audience why they go through so many tests, because always patients look at me when I say, this is what we're going to do, and we have to do X, Y, Z. That's an awful lot, and it seems. And he said, okay, listen, just tell me a little bit about what you're going to talk about. He said, look, there's clearly two reasons why you need to do lots of tests. First of all, we've got to make an accurate diagnosis so that we can apportion you to which of those groups you've just seen on my previous slide. But equally importantly, repeating these tests, some of these tests anyway, are very important to get a real good close-up view on how you're doing so that we can be ahead of the game, so we can bring in changes potentially to treatment before, maybe even before, some of you are recognizing what's happening. And that's a very important issue. So here's a slide with multiple images. On the top, on your left, you can see an ECG. Most of you will have an ECG which can very much help in diagnosis. It can tell us whether that heart's under any strain. More importantly, some of you may have found that you suddenly become breathless, or your symptoms are worse. And it may be that the heart's rhythm, instead of being nice and steady, has become irregular. And that tells us what's going on and how to get you back into a proper sinus rhythm, which is the name given to a nice steady standard rhythm of the heart. Because there's no doubting that the heart is already under some strain. If the heart goes into an abnormal rhythm, then that further compromises how it can function. So that's a very good test on a number of ways. The X-ray number 18 up there, squad number 18. I don't think he was playing for Newcastle, although sometimes when we look at our midfield, probably think they might have done. Very important. It tells us the size of the heart, and we can look at the blood vessels. We can make sure that there isn't anything going on in the lungs that might be actually driving the system. On the top left, we've got an echo, which I guess all of you will have had on multiple occasions as well, because that's a good screening test to tell us what is happening in terms of is pulmonary hypertension present or not. But as I said earlier, it's not a direct measure, and it only gives us a sort of guesstimate of what the pressure may be. Now, that guesstimate, with careful evaluation and expert center use, is pretty good, but it isn't the final definitive way, and it doesn't tell us all we need to know. One step on is a test that many patients don't like. On the middle, on the left-hand side, is an MRI image. That is an image that's done where you have to go through often a fairly small confined area. Some patients don't like it. It can be quite noisy. But it does give us very important information about the blood vessels in the chest and also the functioning of the heart. And then, of course, in the middle and far right is the right heart catheter. Now, most patients, I can see when I say we're going to have to bring you in and put a little needle in your neck, because most of them are done that way in our center. It does vary. You can go, obviously, from the groin or the arm. And most patients, I can see, they're thinking, oh my God, this sounds terrible. But I usually say, look, it's just like having blood taken, only we're using a different vessel. Easy for me, I know. But it is so critical so that we can start the job of getting you better, that we get accurate information. And the right heart catheter is absolutely essential in terms of upfront diagnosis, and in many instances, getting information to tell us whether or not treatment should be continued, increased, or changed. So the moment, although we are increasing our use of some of the other so-called non-invasive tests, the right heart catheter is very, very important. We're not just doing it to keep ourselves in a job or keep us amused or because we like it. It's absolutely essential for you. And then there's breathing tests, the 6-minute walk test, or cardiopulmonary exercise testing. Certainly the latter two, very important in terms of assessing whether or not the treatment is working for you. We've said our comments about the right heart catheter, and as I said before, the standard approaches vary according often to whether it's a diagnostic catheter or a catheter that's being done simply to follow pressure changes within the heart. Now, all of these tests are done because one of the ways that we can assess how you're doing on treatment, are we all in a good, happy situation? Are things improving and stable so that the future's looking rosy, is through what's called the pH traffic light. Red, amber, green. And research is very important in this area and has yielded useful information immediately for us in terms of how we should look at the results of that research and apply it to managing patients like yourselves. Because all of the various areas you'll see on the far left, which is clinical history about how the heart is, and then exercise testing, some blood markers, and then echoes and MRI, and finally at the bottom right heart catheter. By careful analysis of data, we've worked out a traffic system where we can work out whether patients are doing very well, which is obviously we would like everybody with their results in the green, whether they're okay, we can debate and discuss, with one or two areas in the yellow or the amber. But if you're in the red, it clearly tells us, woof, even though you may think, I'm all right, honestly, doctor, and this happens. Doctor, I'm feeling all right. And the doctor's saying, well, I think this helps maybe explain why sometimes we have to discuss changing or increasing treatments, even though perhaps from your perspective, although patients generally know how they're doing, sometimes there are subtleties in some of these measures that help us. So the reason we do the tests is not just to collect information for our interest, it's to collect precise information so we can do the best job for you. And those treatment goals, clearly for you, and we should discuss in every outpatient, are how can we make you feel better? How can we make you function better? What are your particular things on an individual basis that you would like to be able to do, or that you aspire to doing, that we might be able to help? That's important. All the other things are obviously generic or applicable to everybody, but we should try and discuss with you, and you should be prepared to discuss with your doctors the individual aims that you have. Is there anything you can do that might help me do X, Y, or Z? And obviously, ultimately, the aim is to have people living longer, good, quality lives. What are the treatments? I'm not going to say too much about in specificities about treatments, because the next talk is going to cover that. But I will mention some after this. But I would say that much as in Match of the Day, there isn't just Gary Lineker telling us what he thinks about what he's seen on the television. He has a series of so-called football pundits to help. And I often think of the MDT that we have, which is a multidisciplinary team grouping. So all of you, no decision is made. First of all, the decision should obviously be discussed with you afterwards or before to get your views. But at the MDT, when the decision to be discussed with you is made in terms of treatment or whatever really, it's a group of people. It's a group of people with differing skills. I wouldn't, when you look at the sort of team of pundits behind Gary Lineker, I would say there's quite a variation in skills and expertise within those figures there, and you know what I mean. And so we bring a true multidisciplinary team view to what should be done to try and get the best suggestion. And then, of course, that needs to be discussed with you, and your views need to be taken into account, but you need the right sort of advice so that you can make the right decision. So, what about very briefly starting with supportive treatments? We've already mentioned that fluid retention can be a feature of your problem. So water tablets, turning on the tap, and we all know on clinic mornings you never take your tablets because sensibly, if you've got a long distance, I know there's a patient of mine from the west coast of Cumbria who comes all the way to Newcastle, and they'd have a very much longer trip if they were stopping every half hour to lose some water with the tap coming on. But nevertheless, diuretics are an important part of managing some patients. Digoxin, some of you may be on digoxin to help that right heart pump a little better, or to control some arrhythmias potentially. Many of you will be taking warfarin, particularly the CTEPH, or some anticoagulation. And some of you, and I can see around, and having had a quick bacon sandwich at breakfast, there's a number of people here on oxygen, and those would all be supportive treatments, and we may hear a little bit more about those in due course. There is a session this afternoon about exercise training, and I don't know whether you have, in your own centres, had much discussion on this, but there's been a huge change in the way in which we look on exercise and pH. In the very early days, we often advise patients, we wrapped them in cotton wool and said, oh, you must be very cautious in what you do. We still need to be very cautious in what we do, but we're much more encouraging to get people up and about, because sitting around is bad for the muscles and maybe bad for pH in general. And gradual controlled exercise is becoming an increasing focus for us in terms of not just, as a basic kind of supportive treatment to help improve and get those goals that we discussed about earlier. And I know there's a breakout session on exercise training. There's also interesting a research program being led out of Glasgow at the moment. Anyone from Glasgow here? Yeah, is that one hand up there? Yeah, maybe. there's a research exercise program actually trying to quantify how much added health gain there is for patients to exercise. And the exercise is done initially under supervision, and it's all done safely. And it does remind me, many of you here, as you know, there's the representatives of the cohort study. Many of you will have signed up to be part and parcel of research, whether it be just taking blood from you and collecting your data, or initiating new trials, new drugs. And it really is the lifeblood for us going forward in terms of improving what we can do for you, and having a collaboration with you, with your support in terms of research is a vital thing. And I think the PH community and the PH physicians and surgeons interested, we should work, and we do work. It's a very good example of how engaging with patients is very important in supporting our research, because we can deliver, and we can only deliver if we have that engagement with you. So please carry on supporting the research that we discuss with you. I guess in near conclusion, the real great news that's happened over the last decade or so is the number of pH-specific drugs that have been introduced, particularly of value to patients with pulmonary arterial hypertension. And from the early vote, as it were, the majority of you fit into that sector. So this is very, and there's virtually no other disease within the heart, within the chest, where so many new treatments have been made available. Most of those treatments still are targeting three main pathways. You don't need to focus hugely on this, but most of you will recognize if I say you might be on sildenafil or another PDE5 inhibitor, tadalafil, or riociguat. Many of you will also be on an ERA, whether it be bosentan, or macitentan, or ambrisentan. And then there's the prostacyclin, where we would give prostacyclin either intravenously or the nebulized route, and you may be on either iloprost or epiprostanol. Some of you may be on Velitri. And all of these treatments have been well researched. They all are effective individually, and many combinations now. The majority of you, I would guess, will be on combination therapy. And the reason that you're on those is we know that the combinations can be highly effective and more effective than drugs alone. But we would very much judge movements in treatment according to that traffic light system that we talked about before. Those CTEPH patients, any of you undergone the operation at Cambridge to have endarterectomy? There's a hand up, a couple of hands up, very good. So you know you've had your pulmonary artery drain cleaned out by Mr. Jenkins or one of his team. So this is an unusual, well, no, it's one of the big causes of pulmonary hypertension, but it's very different to what we've been talking about before. This is where clots have gone up into the lung, and instead of them being removed by the normal body systems, they stay, they scar, they fur up, as you can see on the left. That's a specimen cored out from that blood vessel that you saw in the movie. So instead of the blood vessel simply constricting down, it actually gets blocked by this organizing blood clot. And actually, Mr. Jenkins doesn't shove a 15-foot drain cleaner down the pulmonary artery. They very carefully open up the pulmonary artery. You'll be asleep, so don't worry if you're waiting for the operation. And you won't know anything about it. And they'll very carefully dissect out that obstruction so that blood can flow. And usually the results are really quite spectacular in terms of restoring patients with this form of disease to getting back to a much more normal lifestyle. And even if the operation itself isn't 100% restoring people back to the level they would like to be, there are now drugs that have been shown to be used alongside the surgery to help. Well, I think that's all I'm going to say, other than, as Ian alluded to, we are the champions of the championship, but it is the only second piece of silverware we've won in the last 20 or 30 years, the only other one being when we were relegated last time and won the championship. Rafa has certainly delivered, and I hope I have this morning. Thank you.
You have delivered, bang on time as well. Bang on time. You get that, Luke? Bang on time. So, we were asked to do a really difficult message, simple, and it was, I think it was Einstein that said, if you can't explain something simply, you don't understand it. So you clearly know what you're doing, Paul.
Thank you.
One final question, because we do have this, and it was asked just before we started, it was this issue about the difference between PAH that we can treat, and there's a lady in this audience who's made friends through social media, through the website of PH, is that she clearly has COPD, and has been told she's got PH, but a referrer or the person looking after a respiratory physician does not want to refer her to an expert PH centre. I know it's difficult on a single case, but can you just give in a minute why that would be the case and the rationale?
Yeah, I could do that. So essentially, at this point in time, patients who have pulmonary hypertension due to lung disease that you have, the drugs that have been very successful in what I call that group 1, PAH, idiopathic disease and congenital heart disease or connective tissue disease, don't seem to be effective. But probably that's because there are a whole range of lung diseases, and the mechanisms or the reasons why pulmonary hypertension can occur in those lung diseases varies a little bit from patient to patient. So the current understanding and recognition is that patients are generally referred to PH centres because they have pulmonary hypertension that the specialist looking after you outside the centre recognises can be treated by the drugs that are only available from the PH centres or the shared care centres that work with the centres. And so the physician looking after whoever it is probably rightly saying, well, if I send you up there, you're not going to have any treatment. However, as a community, we are not abandoning the view that patients like you, there may be a subset of patients that we haven't quite organised our trials best at. And particularly in Sheffield and the Brompton Hospital, there are particular interests in this, but the rest of us would also get involved. We are looking at setting up trials within specific populations of patients with lung disease that might be suitable. So I think the bottom line is it never hurts if you're willing to travel to hear a bit more about what's going on. Maybe going back to your physician and saying, I've just been to the weekend and there are interests, whilst at the moment you're right, there aren't treatments that have proven to work. I might have a form of disease that needs a bit more evaluation, and there might be a clinical trial coming up. I've mentioned research that will look, and I'm willing for that. So whilst you're not potentially suitable for receiving the drugs that many of your colleagues in the audience are on at the moment, there may be features about your particular problem that will be within our target for saying, yes, we're going to set up a study. So I think this is an evolving area, and the important thing is to keep dialogue like this, finding out what's going on, and education. Education is a dual thing. Your doctors don't know everything, we don't know everything. You know things that we don't know. We know things that you don't know. Let's talk to each other and get to the quickest way, to the right way of helping everybody.
Cheers.
Okay.
Thank you. Right, thank you very much.